All right, so continuing on with the urinary system, we're going to take a brief look at infections and some inflammatory disorders. So let's look at infections. Typically, you'll hear the term UTI, urinary tract infection, but there is a such thing kind of similar to the respiratory tract where someone can have an upper respiratory tract infection and they can have a lower urinary respiratory tract infection. Same thing with the GI tract, where we need testing that can go through the esophagus for an upper GI studies, or they have to go through the anus for a lower GI study. So with urinary tract infections that affect the lower portion, we call it a lower urinary tract infection, such as cystitis and urethritis, and upper urinary tract infection, we call it a pyelonephritis. And a common cause of pyelonephritis, we'll see it shortly, is Escherichia coli or E. coli. That is the common cause of upper urinary tract infection. That's what this UUTI stands for. Other species that are associated with urinary tract infection, Klebsiella, Proteus, Enterobacter, Citrobacter, Serratia, Pseudomonas, Enterococcus, Coagulus, Chlamydia, and Mycoplasma. So in terms of etiology, we showed you when we went over the normal anatomy comparing male to female that women have a shorter and wider urethra that's also closer to the anus, so UTIs are much more common in women than in men. Also common in women from sexual activity and also from feminine hygiene products. In men, from prostatic hypertrophy, urinary retention, and infection of the prostate or testes. I have seen a number of women over the years when I test the urine and we see increased white blood cell count, which could be indicative of infection. It's really important to ask about proper wiping. Make sure that women are wiping anterior to posterior, not posterior to anterior. And also about the underwear, the type of underwear they wear. Many women wear thongs, and when that happens, you can think of it as this flossing effect, right? When you floss and you put dental floss between the teeth and you rub it forward and backwards, many times from certain type of underwear, just from standing and sitting, standing and sitting, standing and sitting and walking, you can get this flossing effect of the underwear, again going from posterior to anterior, spreading bacteria. Okay, so have to be very, very careful with wiping and with underwear. With urinary tract infection, sometimes there's congenital abnormalities that are seen in children. Some other common predisposing factors are incontinence, urine retention, obstruction of the outflow that's seen with pregnancy, calculi or stones, scar tissue, direct contamination with fecal matter, immunosuppression, and seen with diabetes mellitus or mellitus due to vascular impairment, issues with the blood vessels, and increased sugar in the urine, which is glucosuria. So here we're looking at some of the common causes of UTI. If we look down here at the bottom, we see E. coli from the intestine moving upward into the urinary bladder, and that can cause cystitis, where you have inflammation around the urinary bladder here, or even inflammation of the urethra as well. And then we have this E. coli ascending up in this direction, up the ureter, through the renal pelvis, and now we have pyelonephritis. And it does look like we have some abscesses that are forming here, which can create necrosis. We can also have blood-borne organisms going down through the abdominal aorta into the renal artery, and then creating an infection here in the kidney. It can happen from stagnation of urine. It can also happen from a vesicoureteral reflux, which happens from a faulty valve. And if there is a faulty valve, you can get this kind of like retrograde flow of urine going from the urinary bladder back up into the ureter, and then as it comes up, it stagnates into the kidney as well. Then we can also have an obstruction down at the bottom. So you have prostatic hypertrophy that's obstructing the urethra, and then you get this backflow and stagnation of urine. All of these can cause urinary tract infection. Cystitis and urethritis. So inflammation of the bladder wall is cystitis, and then the urethra, now we call it urethritis. Okay, so if we go back here, cystitis, and then if you get this inflammation here, urethritis, just add the itis at the end. Signs of inflammation: redness, swelling, and possible ulceration. With irritation, bladder wall becomes hyperactive with a reduced capacity. So the person always feels like they have to urinate, which is an indication of a UTI, possible indication. Also, pain in the lower abdomen, especially if it's ascending from the urinary bladder up the ureters. Dysuria, which is painful urine. Urgency, which is the need to void immediately. Frequency, nocturia. So frequency is the need to go frequently, right? Nocturia is the need to urinate, especially at night. That's nocturia. Some of the systemic signs are fever, malaise, nausea, leukocytosis. The urine will be cloudy, unusual odor. Can also have unusual coloring as well as unusual odor. Very, very common. The UA will indicate bacteria, pyuria, and microscopic blood in the urine as well. The pathophysiology of pyelonephritis: this is an infection of the renal pelvis and the medullary tissue, affecting the nephron, right, which is proximal, distal convoluted tubules, loop of Henle. And again, it's commonly caused by an ascending infection of E. coli. The infection will spread from the ureter. It'll ascend up into the kidneys, and it can involve one kidney or both. There can be purulent exudate that fills the renal pelvis, the calyces, remember the minor and major calyces, and the renal medulla. An abscess can form and cause necrosis in the medulla, but that can also extend to the outer portion called the renal cortex. There can be compression on the blood vessels of the kidney if inflammation is severe enough, and that can result in, especially if it's a recurrent infection, it'll lead to scar tissue formation, and now you lose loss of the nephron function or the tubule function. There can be obstruction in the collection of the filtrate, that's called hydronephrosis, and eventually chronic renal failure if it goes untreated. So again, your brief anatomy. Here, the outer portion is the cortex, the inner part is the medulla. You have minor calyces, which dump into a major callus, and then you have this larger dilated portion, which is the renal pelvis, and this is the ureter. Okay. the outermost portion, which is the fibrous renal capsule. The clinical manifestations of pyelonephritis, it includes the same signs of cystitis, dysuria, urgency, frequency, and nocturia. The pain can be dull, and they can have pain in the lower back very frequently, especially around the flanks, common. There could be a high temperature, and urine analysis will be similar to the cystitis. And oftentimes there are urinary casts that are present, which is damage to the epithelial membrane, and it sloughs off. Treatment is going to be antibacterials. Okay, inflammatory disorders. We have the glomerulus, and now we have glomerular nephritis. This can be caused, the first form of it, we'll call it acute post-streptococcal glomerulonephritis. And this follows, by its name, post-streptococcal, it follows a streptococcal infection with a certain strain of group A beta hemolytic streptococcus. The infection usually originates as an upper respiratory infection or a middle ear infection or the sore throat, right, the strep throat. The acute glomerulonephritis develops 10 to 14 days following an infection of the ear or the respiratory tract, and it's pretty common between the ages of 3 to 7. Now, some of the unique characteristics, there's going to be the presence of ASO antibodies, anti-streptococcal antibodies. So there will be the formation of an antigen-antibody complex. The antigen-antibody complexes deposit in the glomerular capillaries. When the antigen-antibody complexes deposit in the glomerular capillaries, it causes inflammation. And now we have this relay to the complement system. The complement system becomes activated. Now you have this inflammatory process in the glomeruli. The glomerular capillaries become very permeable. So you have increased capillary permeability, which means they're going to become leaky. They become leaky to protein and red blood cells. With a severe inflammatory response, you have congestion and cell proliferation, which results in the decreased glomerular filtration rate. Remember that, the GFR? So with all of this accumulation, it creates congestion. The cells, the epithelial cells, become damaged and they proliferate, and it results in decreased GFRs because the lumen, the space where all the blood is flowing in, is going to be damaged, and you get the retention of fluid and waste products. So what we have this endothelial cell. Here's the opening of the glomerulus, so there's normal blood flow. In mild glomerulonephritis, we can see that the endothelial cell is a little bit swollen here. We start to get a little narrowing of the lumen, so the GFR is going to start to slowly decrease. We have these immune complexes that start to form, and we have more inflammation. And as a result, now we're going to get this permeability or this leakiness of blood and protein. Here it's severe. So we can see, look at the space, you have little blood flow. We call that oliguria. Oliguria is, there's going to be like no urination that starts to form. Look at the swollen cells, a much greater immune complex that develops due to the complement system, and the cells just proliferate, decreasing the lumen size. So as a result, the urine is going to be much darker and cloudy due to the red blood cells and the protein. There'll be more swelling in the body, especially around the face and around the eyes, periorbital edema. So generalized edema follows. There'll be increased in blood pressure caused by the increased renin secretion and the decreased glomerular filtration rate. There'll be flank pain or back pain. You'll see the same signs of inflammation, and there'll be decreased urinary output. As a result, the glomerular filtration rate declines. And as the glomerular filtration rate declines, then renin does its thing, right? Converting angiotensin converting enzyme 1 into 2 to increase the blood pressure, right? By vasoconstricting, it tries to increase the blood pressure. So here we have some sort of strep infection. We get the antibody that forms and it sticks to the antigen. So you get that antigen antibody complex. But remember, that starts to deposit in the glomerulus and it starts to destroy those tissues. So you get this inflammatory response, this acute response. The capillaries become much more permeable, so you get the blood and the protein spilling over. That's albuminuria. The glomerular swells, so you get the congestion. The cells start to proliferate, so you get the decreased glomerular filtration rate. And that's going to stimulate the renin production, which will increase the blood pressure and the edema. So when you elevate the blood pressure, you're going to start to get acute renal failure that can lead to death. Or in some cases, they can have a full recovery. With the blood pressure and the edema, you start to get the chronic glomerulonephritis, where you get more fibrous tissue replacing the healthy glomerulus, and that too can lead to chronic renal failure. Okay. Some of the diagnostic tests for glomerulonephritis: elevated serum urea and creatinine levels. They can look for the anti-DNA, the anti-DNase enzyme. They can look for streptococcus antibodies, anti-streptolysin, and anti-streptokinase. The complement levels will start to decrease. Metabolic acidosis is evident. Urine analysis will see proteinuria, hematuria, and red blood cell casts that are evident. There will be no evidence of infection. Treatment: sodium restriction, right? If you don't hold on to sodium, you don't hold on to water. That's a way of decreasing the accumulation and the pressure. We need to decrease the protein intake and fluid intake in severe cases. And to reduce the inflammation, glucocorticoids are going to be beneficial. And to decrease the high blood pressure, the antihypertensive medications. For nephrotic syndrome, this is caused by a variety of renal diseases and systemic diseases like SLE, or the exposure to drugs that are damaging to the nephron. So they're called nephrotoxins. It can be idiopathic in children 2 to 6 years old. The pathophysiology here is the glomerular capillaries increase in permeability, like we saw before. Large amounts of plasma proteins escape in the filtrate. That's what we saw before. But here we have hypoalbuminemia with decreased plasma osmotic pressure results. This will create subsequent generalized edema. Okay, the blood pressure remains low or normal. It may be elevated depending on the angiotensin II levels. So remember, as the pressure drops, the body is going to stimulate that RAS system to increase ACE, to increase ACE2, to increase aldosterone. When you increase aldosterone secretion in response to the decreased blood volume, you can get more severe edema. You'll get high blood cholesterol. Lipoproteins could be found in the urine. Lipiduria with this milky appearance in the urine. With the nephrotic syndrome, there'll be massive edema. It's called anasarca. That's the massive edema. That is a significant sign. But there'll be this associated weight gain, right? This puffiness and the swelling. They'll be paler due to the vasoconstriction. There'll be ascites, right? That fluid accumulation around the belly that impairs the appetite. There could be pleural effusion, edema and swelling around the lungs, which will impair the breathing. and then both the legs and feet become very swollen. So you have this overall sign of massive edema throughout the body and swelling and puffiness all over. Proteinuria, protein spilling over in the urine, lipids spilling over, casts, and in terms of the skin, there'll be infections and the breakdown of the skin, and that's primarily due to the impairment of the arterial flow and the capillary exchange due to the overall vasoconstriction. The treatment is definitely to reduce inflammation using glucocorticoids. The ACE inhibitors are very common, antihypertensives, and decreasing sodium intake. When we come back, we'll get into urinary obstruction, vascular disorders, and congenital disorders.